My name is Chandler McLeod, and the title of this presentation is Trigeminal Neuralgia. So what is it? Well, trigeminal neuralgia is based around the facial nerve, also known as the trigeminal nerve, or the fifth cranial nerve. So a neuralgia is pain caused by damage or irritated nerves. So in the case of trigeminal neuralgia, it's simply the irritation or damage of the facial nerve, the trigeminal nerve. So what patients usually experience with trigeminal neuralgia, also known as TN, is paroxysmal acute facial pain. So what this means is pain is usually experienced in very acute bursts for 20 to 30 seconds, all the way up to a few minutes. And usually it can be very unbearable during these attacks. The condition is quite rare, 10 to 15,000 cases per year compared to other conditions. And oddly enough, it's most prevalent in women over 50. Now, it's hard to explain why this is the case, but it's one of the mysteries of trigeminal neuralgia that we don't quite yet understand. So how does it work? Well, our current understanding of nerves in the body works something like this. The afferent nerves travel from the nerve endings to the integrating center, and responses are generated and sent down the efferent pathway. In a more detailed case, the peripheral nervous system will use signal transduction to send a signal received at the nerve endings to the central nervous system and then to the integrating center. In the case of trigeminal neuralgia, the pain that's caused by the condition is usually experienced in the peripheral nervous system, where these afferent pathways are seen. Now, the trigeminal nerve is usually causing this pain by hyperexcitation. The most common versions of hyperexcitation seen in TN is vascular compression. This is seen by the veins in the local area around the root of the nerve compressing it via dilation. There's also nerve demyelination, which is seen by the demyelination of the myelin sheaths on those afferent nerves. And so the axons no longer have that protective sheath, so they are affected by outside ions and things inhibiting those signals. In specific cases of patients with MS or multiple sclerosis, there's a buildup of plaque around the dorsal root of the trigeminal nerve. So causes such as these are what leads to hyperexcitation in trigeminal neuralgia. Treatment is very much based on diagnoses. So for classical TN, which is diagnosed based on the list of hyperexcitation causes we saw on the previous slide, is very common. And the treatment for classical TN is seen through first and second line treatments of drugs, specifically anticonvulsant drugs. So the purpose of these anticonvulsant drugs are to inhibit nerve activity and to lower that hyperexcitation of the trigeminal nerve. They're very commonly seen in patients with epilepsy and other neuralgic conditions. Some common drugs that are seen in those treatments as well are carbamazepine, oxcarbazepine, and gabapentin, as well as a long list of many others. Secondary TN is different from classical TN in that those that receive secondary TN are usually generated from an underlying condition that led to that TN development. That treatment is usually based on the pre-existing condition and whatever treatments are applied for that. Now, after drug treatments, there are surgical procedures that can be done to try and inhibit that hyperexcitation of the trigeminal nerve, some of which are radiofrequency and glycerol gangliolysis, which work to make incisions on the ganglion cells to try to inhibit that nerve. Balloon compression, which is a bit of an older tactic that is not as effective, but it works to try to compress the ganglion cells for the same effect. Stereotactic radiosurgery is a more specific, more accurate version of gangliolysis, which works to also make an incision on those ganglion cells. Peripheral neurectomy is seen as a last case scenario, worst case scenario. If it's not capable to inhibit the nerves, then simply performing a neurectomy and inhibiting it altogether will do the trick. And they even go as far to use methods such as cryotherapy. It sounds a little crazy, but even freezing those nerves do a good job in inhibiting the hyperexcitation of the trigeminal nerve. So I included this table in the presentation because I wanted to show what and how physicians approach the diagnosis process for trigeminal neuralgia. So as you can see, they start with MRI or trigeminal reflex testing to see what version of TN you have, whether it's classical or symptomatic, which is basically secondary TN based on an underlying condition. So as you can see, there are drug treatments for both, and then a wide range of alternative treatments and surgery for classical TN. Now it's worthy to mention that these drug doses are based on research for what is best for dealing with TN. Of course, dosages are completely case specific and are best if they are specific for each individual case. So these are simply an inference as to which is best, but of course, physicians will decide what is best for each patient. So what's next? Well, research on trigeminal neuralgia has come a very long way. A few decades ago, we didn't really know a lot about it, and a few centuries ago, we had just started to record trigeminal neuralgia, but we've never really understood it. Even today, there are still mysteries behind this nerve condition. But thankfully, because of the research done, the treatments we have are very high in efficacy, as well as there's a wide variety of them to choose from. So the options are limitless, as well as there's an increased standard of living for most patients that receive treatment. Of course, this is a great improvement. If we have patients experiencing higher standards of living because of these treatments, then research must be doing a good job at increasing our knowledge on trigeminal neuralgia. But as with any condition, there's always much more to be learned. We cannot say that we know enough now to be able to completely conquer this nerve condition. So if we had to approach it in the future, I would say that the best approach is to continue research, to look further into it, and I believe one day we will be able to conquer this nerve condition as well as many others, because it's likely that the more we research, the more we'll find out about the nervous system in the body, which is very complex. But it can never hurt to know more. So one day, we may just conquer this condition. Thank you.